All right, welcome back. So now we're going to be going into renal physiology, which isn't the longest chapter, but I think one of the things that makes it a little long. Oh, sorry, not chapter. It's not one of the longest sections. But one of the things that makes it a little more dense is the whole acid-base physiology. Whenever I do the video on acid-base physiology, I'm going to make sure that I do my best to help you guys really understand how you're supposed to catch what the acid-base abnormality in any given question is, right? Because you often get questions, I'm sure you've all seen it by now if you're doing any practice questions or NBMEs, that there's always going to be that question where they're going to talk about some kind of issue, something the patient was doing, or some kind of clinical presentation, and then the answer choices are all going to be pH, PCO2, bicarb, and then one other thing. Sometimes they throw in a random electrolyte or something else related more so to the actual problem causing the acid-base abnormality. So really important to be able to make sure you don't mess that up, because on your real step one, it's almost guaranteed you're definitely going to have at least 3 questions where you have to pick the right pH, PCO2, bicarb combination for various clinical presentations. As far as renal physiology is concerned, it is critical to really understand two other things, which are the way the different parts of a nephron work, what's being absorbed, what's being put into urine, how that's altered by the endocrine hormones we've already looked at, like aldosterone and ADH, and how you can measure renal activity using things like inulin over here or creatinine, what they're supposed to tell you. And those are the things that are going to come in really important and really critically important when you start looking at questions and they tell you information regarding those topics. So the first thing they talk about here are your fluid compartments. Okay, so there's the 60-40-20, or you could just call it the 6-4-2 rule. The 6-4-2 rule for percent of body weight for average persons, and they take a 70 kilogram, which is about a 150-pound human, right? So that's actually a pretty small person, a 150-pound person. In America, I would say the average body weight is probably around 200. Let's actually check that. Average body weight in America. So see the average American 20-year-old right here, right? The average American 20-year-old and up weighs about 200 pounds, right? So really important to make sure you understand that concept. Let's see, put this back now. My mouse has been acting up. Okay, so they tell you this for a smaller number weight, but the percentage is what allows you to apply it to any weight, right? So you have to remember the percentage. So given any body mass, you can go ahead and use the percentage to break it down. So what is this so important for? So let's just actually understand what's being told, and then we'll figure out how this is clinically relevant. 60% of the total body mass is just water, right? So that's something that we've probably all heard of many times, and common folk talk about it a lot too. 40% of, so that was the 60-40 breakdown first, right? So 60 and 40. Okay, 60 of it is body water. The other 40% of it is the non-water mass. Now here, they're breaking down the rest of it, so 40-20. Right, this 40-20 is the ICF and ECF in this section. Okay, so 40% of ICF is mainly composed of potassium, magnesium, and organic phosphates like ATP. 20% of extracellular fluid, so it's intracellular and extracellular fluid. 20% of extracellular fluid is mainly composed of sodium, chloride, and bicarbonate, and albumin. Right, so intracellular basically means inside the cell. You're going to have a lot of potassium, magnesium, and ATP. So you can see over here, this non-water mass area is pretty irrelevant, so don't worry about this part at all. This is the part that's being broken down. So you can see what they talk about with 60-40-20 is that in the 60, there's a breakdown of 40 and 20, right? Where 40% of it is intracellular fluid, right? So intracellular fluid meaning that this red portion here, including your RBC volume, is where you have all your potassium, magnesium, majority of it. This up here with the yellow and blue, that's 20%, and that's your extracellular fluid, right? So this is going to have your interstitial fluid and plasma in it. Okay, so I added a little more to this because it was kind of important to break it down more in case you see it like this in the question. So you see how 60% times 20%, and we're talking about 70 kilograms, right? That and then the 75% over here for interstitial fluid, all of that, when you do the math, 75% times 20%, you know, multiplication means of, right? So 75% of 20% of 70 kilograms is 15% of your total body mass. Okay, so 15% of your total body mass is this blue area. The yellow area thus must be 5% because the blue and yellow add up to 20, right? So 5% of body mass is just plasma. And then over here, your entire thing over here was the 40%. RBC volume is about 2 to 3%, maximum 4%. Okay, so it's pretty important to know that because you can get a silly question where they want you to just give the percentage or something. It's pretty annoying stuff, but just do your best to understand it. Plasma volume, which we just said right here is about 5% of body mass, can be measured by radiolabeling albumin, right? Because albumin is this ECF portion, plasma. Extracellular volume can be measured by inulin or mannitol. So the entire extracellular fluid, right? The whole thing, the blue and the yellow. Inulin, we're going to see later on what it does, and we're also going to see mannitol later on as well. But just keep in mind, if you ever need to measure extracellular volume, think of inulin and mannitol. Serum osmolality, also really important to know. Just remember, this is the normal. I just think of 290, right? So normal average serum osmolality is 290. Serum osmolality is serum solute concentration. Remember, osmolality and solute concentration are the same thing. You can switch that up. So if your serum concentration of solute should be about 290, if it's too high, right? So if the solute concentration is very high, meaning your serum osmolality may be like 400, 500, 600, it means you're urinating too much of the water, right? You don't have any water in your system. You might be dehydrated, something like that. And if serum osmolality is very low, like 200, then your solute concentration is very low, which means that you might be drinking too much water, or you have some kind of derangement with ADH, which is antidiuretic hormone, so you're not peeing out any of the water at all. Right, so serum osmolality, the normal amount, 290, very important to remember that, because then you'll know when something is wrong if they give you a serum osmolality that's higher or lower than 290. This is the filtration barrier that we were looking at earlier in the last video. So this is responsible for filtration of plasma according to size and charge. Those are the only two real things that are being used, okay? Size and charge. It's composed of the three things that basically all filtration barriers are made of: a fenestrated capillary endothelium, a basement membrane, and visceral epithelial layer consisting of foot processes. Very important to remember that the basement membrane is type 4 collagen, right? We've talked about this before when we did biochemistry. Remember type 4 for the floor, right? So basement membrane is type 4 collagen, and diseases like Goodpasture syndrome, which is a type 2 hypersensitivity because it has antibodies and antigens. Goodpasture syndrome actually attacks type 4 collagen. So when we see Goodpasture later on, this should ring a bell for you. So the two things, charge and size, right? Charge barrier, all three layers contain negatively charged glycoproteins that prevent the entry of negative charged molecules like albumin, right? So there's negative molecules all over here. So that means anything negative can't go past it because like charges repel each other. But positively charged things can go through. And they can only go through if they have the size too, right? So the size barrier, there's a fenestrated capillary endothelium that prevents the entry of things more than 100 nm molecules per blood cell. Podocyte foot processes interpose with the basement membrane, and you get this thing called a slit diaphragm, which prevents the entry of molecules more than 50 to 60 nanometers. Right? So really important to understand that whatever has to pass has to be very tiny and positively charged. Okay, you're going to get questions on that kind of stuff too. Now, this stuff is the stuff that's supposed to go on your cheat sheet. So this whole time we've been putting together a cheat sheet that I've already posted online. When you get to renal, these equations, if you're having any trouble memorizing C equals UV over P, you want to go ahead and put that in your cheat sheet. It's a very easy equation. But if you don't remember it correctly, or if you don't remember what they all stand for whenever you need to use it, then that's something you want to practice and put on your cheat sheet. So basically, clearance is equal to the urine concentration times the urine flow divided by the plasma concentration. Right, so clearance is basically a ratio between the urine and plasma concentration of whatever X is. Okay, so clearance is a ratio of the urine to plasma concentrations, and the urine flow rate helps you understand how quickly something is being cleared out, right? Because urine flows, plasma does not. That's why you have a V in the top. So volume of plasma from which the substance is completely cleared per unit of time. If clearance is less than your glomerular filtration rate, right, GFR, if clearance is less than GFR, that means that you're reabsorbing something, okay? Net tubular reabsorption and or not freely filtered. Really important to understand what's happening here. So basically the concept is that clearance versus GFR, if your filtration rate and your clearance are the same, right, if they're the same, if your clearance and GFR are the same, that means you're neither secreting nor reabsorbing whatever the substance is, whatever X is. But if clearance is less than GFR, right, then there's a net tubular reabsorption, or whatever it is doesn't get freely filtered, so it can't even be cleared, because filtered means that it got sent into the urine. If clearance is more than GFR, then whatever X is being secreted, right? You're putting it into the urine. All right. So this calculation is often going to be something that you'll just use to figure out if whatever the substance X is, are you keeping it? Are you urinating it? What's happening with it? So most nutritional things, such as glucose, amino acids, and many of the electrolytes are reabsorbed at the PCT. So their clearance is going to be far less than GFR. PAH, para-aminohippuric something acid, that and creatinine are moderately secreted. Alright, so they're going to look something like this one, where the clearance is a little higher than GFR. And inulin and urea are freely filtered. They don't have a net secretion or reabsorption, so their clearance is going to be equal to GFR. Alright, the pX, the plasma concentration of any substance that is cleared renally, will be high when the kidney is not functioning well, because clearance will be low. Hence, we give lower doses of medications to the elderly or those with poor renal function, right? This is important because renal clearance is often used to calculate how quickly you're going to clear out a medication that's processed by your kidney and excreted by your kidney. If your renal clearance is not doing too well, then the plasma concentration is going to be really high because you're going to retain it all. So you want to make sure you give people who have renal disease, first of all, you want to give patients who have renal disease medications that don't have any requirement for renal function. But if you have to give them something that requires renal function or renal excretion, make sure you give a very low dose because you know that their renal function isn't that good. This is your glomerular filtration rate, GFR, right? One of the defining features of how well your kidney is working. And they tell you here another equation, GFR is equal to UV over P. This is the same thing, right? Same equation as clearance. Same equation. So it's not a separate equation. The clearance or GFR are basically calculated the same way. The X is what determines what it is that's happening, right? Here, they replace X. Now they're saying GFR is specifically calculated by looking at inulin, right? Urine inulin times the urine flow rate divided by plasma inulin. GFR is basically equal to clearance of inulin, right? That's what this equation is telling you. And this same equation also works with this, something that we saw much earlier, a long time ago in the beginning, somewhere in, I think, cardiology, cardiovascular, regarding whether or not you're going to have higher oncotic pressure or higher interstitial pressure, hydrostatic interstitial pressure. That equation and this equation are the same thing. They're just using different letters because we're talking about a completely different system. But it's the same equation. So this equation, we're going to look at it right now, right here. You remember this thing? So net filtration pressure, we just learned this equation, the PGC plus pi BS, right? The P being the pressure and the pi being oncotic stuff. That's the same thing as the other equation we had earlier for capillary fluid exchange, right? Same equation. Just a different concept, different location is being used, so we have different letters for the variables, but the equation is still the same. So, excuse me. So, inulin clearance is always going to give away how well your GFR is. Sometimes in questions they'll tell you that. You know, in a question they'll be like, "Oh, by the way, this patient's inulin clearance is 100. Normal GFR is about 100. So then that means that the kidney is working fine. But if they give you an inulin that's too high or too low, then you have to figure out what's wrong. Creatinine clearance another important factor more commonly given in questions is an approximate measure of GFR, and creatinine clearance slightly overestimates GFR because creatinine is sometimes moderately secreted by renal tubules. Incremental reductions in GFR are what define the stages of chronic kidney disease. So those incremental reductions are being shown by the four dots over here. So right here on the y-axis we see plasma creatinine. On the x-axis we see glomerular filtration rate. Be very mindful of this graph. This graph represents the relation of GFR to plasma creatinine, which is the most common indicator of kidney function in clinical use. You've probably seen creatinine being given to you in many questions. Serum creatinine rises when GFR is less than 60. So you can see at this point where you would have the 60, when GFR is less than 60, you can see how high creatinine is going. So we're supposed to say, let me get the pencil real quick. So you can see like right here would be normal function of your GFR, because normal GFR is about 100, and that would equate to about a 1, which is your normal creatinine. Okay, now as you go in this direction, right, that when GFR is getting lower and lower and lower, you can see creatinine is getting very high. Usually in a question when we see somebody has a creatinine of 2, right, we automatically say they have impaired renal function, which means their glomerular filtration rate is somewhere around 60 and things are slowing down. That's not good. That's not what you want it to be at, right? And once it starts going in this direction, it's only going to get worse. Chronic kidney disease is progressive. It doesn't stop or get better per se. It just keeps getting worse over time. Serum creatinine rises when GFR is less than 60 and begins to rise rapidly as GFR decreases. But when GFR is normal, relatively large decreases in GFR lead to only small increments in creatinine. You can see when creatinine goes from 100 to 125 to even 150, when GFR goes from 100 to 125 to even 150, the creatinine is still 1. And similar the other way, from 100 to about 75, it's only a tiny jump from maybe 1 to 1.5. But that's why even small increments in creatinine are a big indicator to us that something's not right. Right? So therefore, serum creatinine is an insensitive indicator for decreasing GFR when creatinine levels are normal. Right? So anytime creatinine level is normal, you don't say, oh yeah, because remember sensitive is snout, right? Sensitive things let you rule out problems. We just said that creatinine is insensitive, which means that if you see a normal creatinine, it doesn't mean that you can rule out kidney disease. But when you see a bad creatinine reading, that does mean that you can rule in kidney disease, and then you got to figure out what the kidney disease is. Right? So a normal creatinine does not guarantee anything. That's what you really want to make sure you understand. Insensitive indicator. Because creatinine changes over here, you can see on the other side of this axis, right, going in this direction, creatinine is not really... creatinine doesn't have much space for change, actually, right? Because it's already pretty much at 1. There isn't much space left to change. And in this direction also, you can't really see much change until things get really bad. So creatinine, not so sensitive. Don't use creatinine to rule things out, but you can use it to rule things in, right? Specific. Creatinine is pretty specific. It lets you rule things in. If creatinine is high, you know for sure there's kidney issues. Okay, so that's it for that. Last thing on this page, you have your effective renal plasma flow. So what is this about? ERP. Effective renal plasma flow can be estimated using para-aminohippurate or hippuric acid, PAH, clearance. Okay, so now your X in that equation becomes PAH, right? Between filtration and secretion, there is nearly 100% excretion of all PAH that enters the kidney. Right? So any PAH that goes to the kidney has to be urinated out. So effective renal plasma excuse me. Effective renal plasma flow is equal to urine PA times urine flow rate divided by the plasma PA, which is your clearance of PA. Renal blood flow, another thing that you can often get questions on to calculate, really annoying questions. Renal blood flow is equal to renal plasma flow divided by 1 minus the hematocrit. Okay? So this is something that's really so unnecessary to test us on this, but you can get a question on it, so be ready, right? This is something you should put on your cheat sheet too. Just have it there, know how it works, memorize it if you can. It's not that ugly of an equation. But yes, renal blood flow is plasma flow divided by 1 minus the hematocrit. Your hematocrit is usually a number less than 1, so that's why it's 1 minus hematocrit. Usually 20 to 35% of cardiac output. Okay, so your renal blood flow should be about a quarter of your cardiac output, which is a lot, right? A quarter of the blood that comes out of your heart goes to your kidneys. Plasma volume, another really unnecessarily annoying thing to calculate, is TBV times 1 minus hematocrit, right? And that's another really rare, actually this is pretty rare as heck. Like, I've never really seen this thing being questioned on, but you never know what's going to be on your test. So just add it to your cheat sheet, just write it down over and over until you remember the equation. Effective renal plasma flow underestimates the true renal plasma flow. When I was first studying this, I was pretty annoyed that they tell you this, right? Effective renal plasma flow underestimates the real renal plasma flow, and creatinine, right? Creatinine overestimates GFR. I don't know if you're really ever going to get a question on that, but that's just something that they keep mentioning. Now here in this image, right? Renal blood flow is related to hypertension, obviously, right? Because blood flow, so that's going to be a blood vessel. If a patient loses one kidney, more blood will flow through the other kidney, causing hypertension and arteriolosclerosis of that remaining kidney's vessel. This is like a pathophysio type of topic you can get a question on, so really important to remember that. We can see here in this picture, right? Amount of blood in the vessel, diameter of the blood vessel, and blood pressure. When everything is normal, blood pressure is normal, which is not going above that line. When you have too much blood coming into a normal diameter blood vessel, blood pressure gets high. Okay? Or if you have normal amounts of blood going through a narrow blood vessel because you actually have high blood pressure, that also makes things even worse, right? So these are all scenarios that you have to be very careful of, and these are the ones where renal blood flow or renal plasma flow are going to be important to calculate. So before moving on, let's just take a look at some of these questions over here, right? So it's first one up here. These are all from, this one's from Euro, these are from AMBOSS. They tell you creatinine, what do they tell you about creatinine? Oh, okay, creatinine. So they tell you about the creatinine in urine and serum. The urine creatinine is 110 and the serum creatinine is 1.1. Glucose in the urine is 0 and the serum is 80. Potassium in the urine is 50 and the serum is 4. Uric acid in the urine is 15 and then the serum is 3. And Pa in the urine is 100 and then the serum 0.2. They throw all that data at you real quick and then they're like, what is the best estimate of the filtration fraction in this patient assuming a urine flow of 1 milliliter per minute? Filtration fraction is actually a really easy equation. This is GFR divided by renal plasma flow. But the harder part to this is knowing what renal plasma flow is, right? In fact, even GFR, those are the two things we just looked at. How do you calculate GFR? How do you calculate renal plasma flow? Then you can find a filtration fraction. So you know GFR can be determined using creatinine, since it and inulin are freely filtered without any absorption or secretion. And renal plasma flow can be determined using PA clearance, since almost all PA entering the kidneys is going to be urinated via tubular secretion. For this question, creatinine and PA clearances are as follows. Clearance is always urine concentration times urine flow divided by plasma concentration. The creatinine clearance is 110, right, because in the urine it's 110, times 1, they tell you the urine flow rate is just 1 for easy math, divided by 1.1, which is the plasma urine concentration or serum urine concentration. So you do the math and you get 100, okay? PA clearance is 100 times 1 divided by 0.2 because, again, urine PA is 100, serum or plasma PA is 0.2. So 100 divided by 0.2 is basically 500 milliliters per minute. So now from these values, filtration fraction is 100 divided by 500, which is just 20%. This is actually a very easy question. It's a giveaway question. You should have no issue solving it. You just got to spend a little bit of time really understanding that clearance of things is what really helps you find GFR and plasma flow. Once you understand that concept, it's not so bad at all. So, that's, I guess, what you would really spend a little bit of time on, just mastering this equation of clearance, understanding that it's inulin, which helps you find GFR, and it's Pa that helps you find renal plasma flow. Once you know that, you can find filtration fraction, which is actually GFR divided by renal plasma flow. And that's it, right? So basically, FF is GFR over RPF, which is creatinine clearance divided by PA clearance, and then you can just plug everything in as given, and you get your answer. So not something you should ever need to get wrong. There's no need to get something in math wrong, because you could just plug the numbers in. So it's really important to know how to plug the numbers in and what the equation is. These next two questions are from Amboss. This one says, a 68-year-old male comes to the physician for evaluation of right flank pain. He has a history of diabetes and peripheral artery disease. His blood pressure is super high, 160/90. Physical exam shows abdominal tenderness and right flank tenderness. An ultrasound shows dilation of the right ureter and renal pelvis. Which of the following is the most likely underlying cause of this patient's condition? So, common iliac artery aneurysm was the correct answer here, 23%. But 20% of people chose recurrent UTIs and 18% chose BPH or urethral stricture. Basically saying that no one really knew what was happening in this question. Alright, so this is a really interesting question. This patient's unilateral hydronephrosis is most likely caused by urinary tract obstruction, right? That's super obvious. It can't be anything else because it's unilateral. And this is a grown adult, right? It's not a neonatal kind of thing. It's a grown adult. They tell you the ultrasound has right ureter and renal pelvis, so the uretero-pelvic junction, which is, again, remember, the most common place for obstructions. So there's dilation in that area. So you had to pick what could have possibly caused, an obstruction at that area in a grown adult. It couldn't be the recurrent UTIs, right? In fact, if anything, recurrent UTIs are going to be the complication that's going to arise because of the hydronephrosis. It couldn't be BPH because BPH would cause it bilaterally, not just on one side. And urethral stricture would have caused the urethra to close up, which would then cause hydronephrosis in the bladder as well, right? The bladder would also be extended, and both sides would have hydronephrosis, not just unilateral. This patient's right flank tenderness, abdominal pain, hypertension are all symptoms of urinary tract obstruction, which can over time lead to hydronephrosis. The middle portion of the ureter runs anterior to the common iliac artery on its way from the kidney to the bladder. Although rare, large aneurysms of the common external or internal iliac artery may compress the ureter, causing an extrinsic urinary tract obstruction and resulting in unilateral hydronephrosis. Alright, so this was a really interesting question. A lot of people got very mad about this type of question because they're like, they've never seen something like this before. Definitely not on UWorld either. But it's a very legitimate question. Totally makes sense. And I feel like this was a good question also because the other things you know really well, like BPH and urethral stricture, recurrent UTIs, those are things we understand. Now you have another thing you can think of, which is remember the water over the bridge and all of that stuff, right? The ureter goes over the iliacs, right, and under the bridge. So that was later on, but over the iliac. So if the iliac has a aneurysm, that can compress your ureter. Very important to remember that. Down here is just another question about calculating stuff. So an investigator is studying the effect of antihypertensive drugs on cardiac output and renal blood flow. Okay, so just a quick revision. We just saw that a quarter of your cardiac output goes into renal blood flow. For comparison, a healthy volunteer is given a placebo and a continuous infusion of PAH to achieve plasma concentration of 0.02 milligrams per milliliter. His urine flow rate is 1.5, and the urinary concentration of PA is 8. His hematocrit is 50%. What best estimates cardiac output in this volunteer? Fortunately, if you just remember this equation, you just plug everything in. Right, so renal plasma flow is equal to 8 times 1.5 divided by 0.02, which is 600. Right, and remember renal blood flow is going to be 600 divided by 1 minus 0.5. Okay, so 1.2 liters per minute. You just plug it all in. That's going to be 20-25% of cardiac output. So that means 100% must be between 4.8 to 6. And the correct answer was just 6. That was the only answer you could pick. The other numbers didn't match 4.8 to 6. Basically, remember that when you calculate this, it gives you the 20-25%. So you have to multiply by about 4 to 5 to get the full 100% cardiac output. Not an easy thing, but it's only just using equations from here. That's all it really was, right? Renal plasma flow is urine PA, which is 8, times urine flow rate, which is 1.5, divided by the plasma PA, which is 0.02. You do that, and you get your renal plasma flow is 600. Then you can use the renal blood flow equation, because you have your renal plasma flow. They gave you hematocrit. So renal plasma flow we already found is 600. And then hematocrit they told us 50%, so that's 0.5. And you get 1.2 liters per minute. So renal blood flow is 1.2 liters per minute. That's a quarter of all your cardiac output. So you multiply by 4 and you can find what your cardiac output must be. Alright, so these are two really nice examples showing you how to use all the equations on this page. Right? And that's how you're going to be applying it in your questions as well. Make sure you understand it. Not necessarily memorize it per se, but write it down on your cheat sheet and use it correctly when you get a question on it. Not something you want to mess up. It's pretty straightforward, and you should be able to solve that. It's just basic math, right? And that's all they're expecting you to do for such questions. In the next video, I'll go into talking about the nephron and how it works with different situations like dehydration or ADH activity, and etc. So thanks a lot for joining. We'll keep going, and I'll see you guys later on.